Bismillahirrahmanirrahim. Assalamu alaikum, everyone. I am Dr. Sadia Noor, and I am the coordinator of this lecture series. And today, our lecture is on the topic of regional blocks and updates in pain management in gynecological procedures. Our speaker today is Dr. Azhar Rehman, and he's working as a consultant anesthesiologist at Azhar University Hospital, Karachi. And he was also the ex-director of Acute Pain Management Services. Before we start, I want you all to remind that kindly keep your mics off during the lecture. And if you have any queries, any questions, write them in the chat box. We will answer them at the end of the lecture. And the certificates for this lecture will be provided at the end in the chat box. Link will be provided. You have to fill the feedback form, and the certificates will be emailed to you. Secondly, the mode of conversation throughout the lecture will be in English because we have international participants as well. So I request you to keep the mode in English. Now I will hand over to Dr. Azhar Rahman. Thank you, sir.
Thank you, Dr. Sadia Noor. Assalamu alaikum and good evening to all of you. A very important topic that I'm going to discuss today with you. Most of us are practicing gynecological procedure, anesthesia for gynecological procedures. And we know that despite significant progress in our comprehension of mechanism of pain, pain physiology and pharmacology of the pain medicine, post-operative pain management still remain a major challenge in the medicine. And we know that insufficiently treated post-operative pain, it impairs the post-operative convalescence in many ways, and thus also influences the perioperative morbidity and the duration of hospital stay. So, despite the advancements made in some areas with regard to the treatment of postoperative pain, the quality of postoperative pain management is generally unsatisfactory, not only in our region but also in first world countries such as in Europe and in United States. These studies, the data that reflects that roughly around 70% of the patient after post-surgery, they come to the emergency with the chief complaint of pain. Similarly, the data from China that reflects around 45% of the patient, they come with a complaint of pain after a major surgery. There is another very important factor that it has been seen in the literature that patients who are coming for the minor procedures, they are usually more unsatisfactory as compared to patients who are coming for the major procedure. So one of the reasons for this discrepancy could be the patient's expectation. Those who undergo major operation tend to anticipate and accept pain. So it is very important in general practice that whatever we are practicing, that should be evidence-based. I've gone through the literature. I've seen the commonly performed procedures. Although I cannot cover each and every aspect, but most of the things you can say around 90% of the procedures would be covered in this talk. And the major literature that I've seen is from the prospect guidelines, which is the procedure specific postoperative pain management, published by the European Society of Regional Anesthesia. The other guidelines which I've seen is the Canadian College of Obs and Gynae and British Pain Society and NICE guidelines, which are the National Institute for Health and Care Excellence. So there are guidelines, but prospect guidelines are a little bit distinguished because they have published these guidelines which are procedure specific, along with the level of evidence. Although you will find the evidence in others guidelines as well, but most of the guidelines, they are not procedure specific. So before going to proceed further, we should have a crude idea about the anatomy of the pain, which the patient suffer, which the patient feel during the or after the gynecological procedures. So the main supply, okay. Main supplies from the visceral pain, the fibers that covers T10 to L1, these are the sympathetic fibers that on stimulation, it gives the pain. The other fibers, which are the parasympathetic fibers, arises from the S2 and S4. These are the fibers which are mainly responsible for the transmission of the pain. When just for to refresh your knowledge, when these receptors are stimulated, the nociception, that is the pain sensation, that is carried out through the first order neuron by the unipolar cells. Here you can see in the diagram the sensory neurons that carry the pain sensation. Um, these fibers, their cell bodies lies in the dorsal root ganglion, and one end is going to the dorsal horn of the spinal cord, where the synapses with the second order neuron. Now, at this point, either the fibers they ascend 2 to 3 levels or descend and then decassate on the opposite side and goes upward toward from the spinothalamic tract in the medulla oblongata. Now at that area, third order neuron that arises and primary sensory area, they ends there. So this is a simple schematic diagram of the pain fiber. So if you look at this figure, which is made simple, in reality, pain pathway is not that much simple. Here you can realize that there are different ways to treat the pain. Either we can stop the pain at the skin level, the area from where the incision is given. We can block the conduction at the first order neuron. We can perform some nerve blocks. At the spinal level, we can manage the pain, or at the higher level in the brain as well. So by looking at this figure, now you can imagine, you can recall different medications which have different mechanism of actions, mode of actions that works independently and sometimes overlap the action and blocks the pain at different level and different neurotransmitters which they block. So the concept of multimodal analgesia that comes from here. So, what is the major aim of the post-op pain management? Number one is to reduce the patient suffering. I'm not using the word pain here. I'm using the term suffering because it's a collection of a number of things. Patient cannot do the routine work. Patient cannot sleep appropriately, appetite, nausea and vomiting. Patient cannot mobilize independently. So this is the basic aim of postoperative pain management. If you are addressing all these things, if you are able to resume all these things, then this means that your pain plan is very effective. Here you can see a graph. You can see different medications along with the doses. On the y-axis and on the x-axis, you can see the number needed to treat that pain, a standard pain. So here you can see paracetamol at high dose is required to cope up the pain. Even with higher doses, you cannot address the pain appropriately. Similarly, if you come up, the COX-2 selective inhibitor, they are more effective in controlling the pain. So by looking at this graph, you can see that paracetamol, although we give it very regularly, it reduces the requirement of opioid, but it cannot be given as a sole agent. It also helps in reducing the doses of the opioid. Um, Okay. So the first procedure that I'm going to discuss is the total laparoscopic hysterectomy. It is not the open hysterectomy, it is laparoscopic hysterectomy. Here you can see the port sides, all are just below the T10 level. So if you go through the guidelines, recent guidelines that was published in 2022, they have mentioned some pre and intraoperative interventions. They have recommended the use of paracetamol along with NSAIDs. In NSAIDs, they have recommended the use of COX-2 selective inhibitor. Uh, why they have mentioned the COX-2 inhibitor? Because the reason which they have mentioned, they mentioned that if you are using non-selective COX inhibitor, there are chances of having perioperative bleeding. Then dexamethasone they've mentioned. Again, this drug is not only used in the pain management, but it's a number of things such as post-operative nausea and vomiting, and they have recommended it with a strong grade of recommendation. Epidural analgesia, it's very surprising thing because in most of the laparoscopic procedures, they never recommend epidural analgesia. But here they have mentioned, although you can control pain by giving the epidural analgesia, it is not highly recommended. If the patient is very fragile, you cannot give the deep general anesthesia. In such cases, you can go for the epidural analgesia, but not as a routine technique. And obviously, for patient comfort, they have highly recommended to go for general anesthesia. In postoperative intervention, again, paracetamol is recommended along with the NSAIDs, especially COX-2 inhibitors. Opioids are indicated if there is a breakthrough pain, just as a rescue analgesia. Otherwise, it's better to avoid opioids as much as you can. And what they have not recommended because of the insufficient evidence, use of pregabalin, use of dexmedetomidine, use of NMDA receptors, antagonist, agonist, IV lidocaine, tab block, intraperitoneal installation of local anesthetic agent, and port side infiltration. And what they have seen, what they have mentioned that data is insufficiently giving the benefit of using all these modalities, so it's better to avoid. Similarly, the other medication which they have not recommended is the intrathecal use of different additives, rectus sheet block, field block, non-pharmacological therapy such as music, etc. They haven't mentioned the use of these therapies. Now, a very commonly performed procedure that is total abdominal hysterectomy. Um, Here they have mentioned grade A evidence, a very strong evidence, the role of cognitive intervention preoperatively. But they have seen that all those patients who had a cognitive intervention, they experience less pain as compared to those patients who do not underwent cognitive intervention. Then pre and post-operative gabapentin for abdominal hysterectomy open. If we compare it with the laparoscopic hysterectomy, there they have not recommended the use of gabapentin. Then again, COX-2 selective inhibitors are indicated here, and they have not recommended the use of conventional NSAIDs, non-selective, a very common medicine, tramadol, which is again a toradol, a ketorolac that we commonly give, and IV. Okay, then they have mentioned the role of combined spinal epidural anesthesia in such a case where general anesthesia cannot be given or it's not suitable because of the comorbidities or because of their comorbidities. Then epidural plus light sedation or general anesthesia in very high risk patient. But again, this epidural has a very low grade of recommendation, that is grade D. Intraoperative, strong opioids are recommended. Again, this is quite a surprising thing. Wound infiltration is recommended here, which was not recommended in laparoscopic hysterectomy. Then different blocks can be used here, such as tab block or QL block can be used. Postoperative gabapentin and conventional NSAIDs can be given here. Opioids, weak or strong, can be given, and paracetamols can be given. Now, when I was searching for the guidelines for total abdominal open hysterectomy, I was unable to get any guideline that was published in the last 5 years. Although there are individual studies, there are a number of studies in which they use different modalities, but I was unable to get the any strong evidence supported by a number of studies. Uh, Even this guideline, which I found, it was published in the year 2006, almost 22 years back. It was formulated and published 20 years back. So in last 20 years, a lot of the things have been in practice. So to me, this guidelines is not very much reliable because new interventions, some new blocks have been introduced, and there are a few things which were recommended 15, 10 years back, which are now not recommended, such as strong opioid, which is mentioned over here. Nowadays, strong opioids is only indicated for rescue analgesia. Okay, so in similar guideline, they haven't recommended the use of NMD receptor antagonist, benzodiazepine as a systemic or in epidural, pentazocine, etc. Similarly, intramuscular, intranasal, sustained release medications, they haven't recommended. Okay. So the next very important and commonly performed procedure is the open laparotomy for the debulking surgery for malignancies. Very extensive surgery is carried out. So in most of the cases, classically, large midline incision is given for the debulking surgery if it is performed open. Laparoscopic procedures are most of the in Asian countries, it is not performed here. So for open laparotomy for debulking, they have recommended the use of IV paracetamol along with NSAIDs and COX-2 inhibitor. IV lidocaine infusion, again, they have recommended it. IV opioid if patient is feeling pain intraoperatively. Then they have mentioned with a grade A recommendation the use of thoracic epidural analgesia as a first line of treatment. And they are talking about the continuous epidural infusion. Uh, Preoperative bilateral tab block can be performed if you are not placing the epidural due to the lack of expertise, unavailability of the material, or if there is some certain contraindication. Similarly, postoperative continuous pre-peritoneal infusion of local anesthetic agent is recommended here if you are not going for thoracic epidural. So, extended release opioid they have not recommended dexmedetomidine, use of pregabalin, duloxetine, certain other regional techniques such as a rectus spinae block and bilateral rectus sheath block they haven't recommended. If you go through the literature for the erector spinae block, it has been said that this erector spinae block, if you're placing bilateral catheters, has replaced the epidural. So, but here the I think this guideline was published in the year 2023 or 21. So they have mentioned this that erector spine block is not recommended in debulking surgery if you're going midline incision. So again, it's a relatively a new thing or a surprising thing for me, at least for me. Now, the most commonly performed procedure that is called the cesarean section, they have recommended the use of intrathecal or epidural opioids. In our region, we don't have preservative-free morphine. So if you have preservative-free morphine, you can use it intrathecally or in the epidural. Although in some centers, fentanyl is available that is added in the epidural as an additive. Paracetamol IV can be given if LFTs are normal. Intraoperative interventions you have to do after the delivery of the baby. Paracetamol and NSAIDs COX-2 selective inhibitors are recommended rather than the non-selective. Dexamethasone and local anesthetic techniques, regional blocks are indicated. On the top of it is the tab block. Postoperatively, along with the other therapies, they have mentioned the role of TENS as well, which is transelectrical nerve stimulation. specifically in post-cesarean patient. Again, it's a very surprising thing because this non-pharmacological technique is usually not recommended post-operatively, but here they have recommended it. So the analgesia strategy is, as I've already mentioned, it should be multimodal. Systemic medication along with regional techniques, if you're expert in it, should go for it. Local infiltrations as an alternative uh, can be done. Adjuvants should be used, such as NSAIDs and gabapentin, wherever they are recommended. Okay, so the now question arises, why regional blocks improves outcome? So they reduces the opioids use. So all the side effects that are occurs due to the use of opioids, we bypass all these side effects. It improves the recovery, and it has been shown in the literature that by using the nerve blocks and by avoiding the opioids, there is a lower incidence of the postoperative nausea and vomiting. So the most commonly practiced block for gynecological surgery is the TAP block. Um, so its anatomy is very important. There are three layer of muscles in the lateral and anterior abdominal wall: external oblique, internal oblique, and transversus abdominis. These three muscles. The targets are when you give the local anesthetic agent, it is said, literature has shown the dermatomes from T10 to L1, they get blocked. Ajay, you may find a little bit variation in the literature. Somewhere it is mentioned T9 to T12. In some literature, it has shown T12 to L1. So there could be a little bit variation. But in general, T10 to L1 dermatomes are blocked if the patient's height is ideal and you are giving the sufficient amount of the local anesthetic agent. As a general principle, whenever you are doing the facial plane blocks, you need a larger amount volume of solution, local anesthetic agent, to spread on that plane and to block the nerves. Because in the plexus block, we directly block the nerves. There, little volume is sufficient to block that plexus or individual nerve. So here you can see in the figure, anterior abdominal wall. In the midline, you will find the rectus abdominis muscle bilaterally. And as you go laterally, you can see external oblique muscle. Below is the internal oblique muscle. You can see the fibers running obliquely. And under that, the final layer is the transversus abdominis muscle. So the aim is to deposit the local anesthetic agent on above the transversus abdominis muscle and below the internal oblique muscle to get the desirable effect, because the nerves are running over the transversus abdominis muscle. So here is the cross-section diagram. Here you can see the ventral rami running across the muscle. Here you can see the three layers of muscle: external oblique, internal oblique, and transversus abdominis. And the local anesthetic agent is deposited just above the transversus abdominis muscle that has blocked the lateral and anterior cutaneous branches. So it blocks the sensation, but it does not provide the visceral analgesia. Okay, it can be performed in three ways. The classical tab block, that is performed in the mid area between the subcostal margin and iliac crest in the mid-axillary line. You just locate the pettit triangle and give the 20 ml. In general, you have to calculate the safe dose and give the that dose to the patient. So in general, 20 ml is given on each side. If you are giving the fenestal incision, so you have to block on the both side. So another modification is the subcostal tap, where you keep the probe just below the costal margin and block it. So here, if you are doing the subcostal tap, you can block the up to the T6 fibers as well. Similarly, the classical technique, which is the lateral technique, another one is the anterior technique. So there are certain three total of three types of tap block that you can do. So classically, you can do the classical tab block to get the desired effect. Okay. Here you can see the ultrasonic view. Um, so in most of the blocks, you use the linear probe having high frequency. So this is very classy. In most of the patients, especially in female patients and elderly patient, you cannot find uh, such a beautiful picture. Most of the time, you find very thin muscles, and you may find a thick layer of fat above the external oblique muscle. So this is quite bookish and very classical. So another very important block is the rectus sheath block. Um, if any procedure in which the incision is given midline as an alternative to the epidural, rectus sheath block can be performed. In rectus sheath block, this meeting has been, that's okay. Okay, so in rectus sheath block, you have to identify the rectus muscle. In the midline, you will find the linea alba. In the rectus muscle, the anterior cutaneous nerves are emerging. So the target is the posterior sheet. These three muscles, external oblique, internal oblique, and transversus abdomen, they when they come medially, they join to form a sort of sheet, and the rectus near the rectus muscle, they split and form the anterior and posterior sheet, and in the midline, they again join to form the linea alba. So the fibers that are running through the rectus sheet are from T7 to T12. In some literature, they have mentioned T8 to L1. So these are the fibers that we need to block. So again, it's a relatively an easy block to perform, but the posterior rectus sheet, there is no other muscular layer below it. So it is very important to visualize the needle. Otherwise, you may go directly into the gut as well. So here you can see a classical picture, just like some sunglasses like image is coming out of it. Here you can appreciate the linea alba in the middle and two rectus abdominis muscle on the each side. So for midline incision, you can your local anesthetic solution should be deposited in the posterior rectus sheet, and you will find the spread of the local anesthetic agent. It will do the hydrodissection. Muscle will get separated from the sheet as you inject the local anesthetic agent. Um, Here again, 20 to 30 ml is recommended to give on each side in an adult on of an average height patient to get the desired effect, and you have to perform it bilaterally to get the desired effect. Okay, around, most of the time we do the single shot block, but even catheter can be left in this space after doing the hydrodissection, and a continuous infusion can be given through it. Here you can see the rectus abdominis muscle, and in figure B, you can see the spread of the local anesthetic agent. So when you start giving the drug, it will simply it will show as a muscle is peeled off from the posterior sheet. So you will find this splitting here. If the local anesthetic agent is spreading within the muscle, it means that needle tip is not as at the desirable place. So you have to make the readjustments. Now, another very important block, relatively a newer block, that is the quadratus lumborum block. So, two very important structures you have to keep in mind. One is the quadratus lumborum muscle. Another one is the thoracolumbar fascia that is covering the quadratus lumborum muscle. So if you look at the anatomy and this quadratus lumborum muscle that is arising from the lower border of the 12th rib, and it is going till the inner lip of the iliac crust. And medially, it is attached to the transverse process of the vertebra. Previous two blocks, which I have discussed, in that linear probe was required, but in QL block, as it is labeled as a deep block, and it is considered as an advanced block. In this block, you need a curve probe to get the desirable effect and to visualize the underlying structure. Quadratus lumborum block, it has three variation, QL1, QL2, and QL3 block. QL3 is also called a transmuscular block. So here you can see a cross-sectional area. Here you can see the external oblique, internal oblique, and transversus abdominis. As you go posteriorly, you will see the latissimus dorsi muscle, and below it is the quadratus lumborum muscle. Acha. And if you keep going posteriorly, you will find the erector spinae muscle. And anterior to quadratus lumborum muscle, you will find the psoas muscle. So anterior to the quadratus lumborum muscle, the ventral rami is coming out of it, and then it is going above the transversus abdominis muscle. So the nerve is the same, but you are blocking it at the level near to the central area. So I'm sure this picture is quite clear. Okay, I was talking about the variation of the QL1, quadratus lumborum, block 2 and 3. If you are going laterally and blocking at the near the transversus abdominis, external oblique, internal oblique muscle, this is called the QL1 block, which is the classical quadratus lumborum block. At this level, the studies have shown that you will get a block of T12 to L1 nerves, and in QL2 block, in which you have to go posterior to the quadratus lumborum muscle. Here you can see in the figure where QLB2 is written. It is deposited, and here you will find the block from T10 to L1. A little bit variation you can find regarding the dermatomal block, depending upon the patient's anatomy, depending upon the dose that you are giving, depending upon the volume that you are giving to the patient. Then finally, the QLB block, which is also called the anterior block, where you aim to give the drug just anterior to the muscle. Again, all these muscles, this your drug you are giving into the thoracolum lumbar fascia, you aim for that. You give in it. One thing that is very important to understand, especially regarding the QL3 block, in which we are giving the medicine anterior to the muscle, that at this level you may find the lower pole of the kidney, especially during deep inspiration. So there are chances of having the trauma of the kidney as well. So one should be very, very, very watchful. It is very important to have a look of the needle tip in order to prevent any injury in it. QL3 block, otherwise it is said that it has a more dense effect. It has some visceral component as well, along with the dermatomal block. and the duration of block is more in QL3 block as compared to QL1 and QL2 block. And the reason, obviously, it's not very clear. Here you can see the transverse process. Okay, when you are performing the block, it is said to start from the midline. You have to see the transverse process of the spine at the level of L4, and you go laterally. As you go laterally, you will find the transverse process, and this transverse process will appear just like as a thumb sign. It is also called clover sign, or it is written as a shamrock sign as well. Shamrock is this flower or having three petals. Here you can see the QL. It represents the one petal. Erector spine is the second petal roughly, and psoas muscle is representing the third petal. And this transverse process, it is the stalk. So in QL, when you are able to see this relatively a darker muscle, quadratus lumborum, you aim to inject the at the anterior level, and you see the spread of the local anesthetic agent. Again, uh, it is recommended you can go up to 20 ml on each side if you are doing it bilaterally. Relatively, it's a newer block, although it is in practice for the, I think, for the last decade, but relatively, it's a newer block. Then for there are certain other blocks they have mentioned, such as paracervical block, which is useful for DNC and hysteroscopy and for loop electrosurgical excision procedures, in which the hyperplastic area is removed by doing the electrosurgical excision. As I mentioned earlier, that if a patient is coming for a minor surgery, they have high expectation of not having pain. But if they are coming for a major surgery, it is in their mind that they are undergoing for a major surgery and they expect that pain will occur. So a patient become very unhappy, especially if they are coming for these minor procedures, if they get pain. Now, paracervical block, I haven't seen any anesthetist in our area, in our region, to performing this block. But again, this is although this block is being performed since for many decades, but for us, this is a newer area to expedite, especially if you are proceeding. You can do these procedures along with sedation by placing these paracervical block. Especially for the female anesthetist, it is more convenient to perform it. So, with the help of the speculum, you identify the four areas and give the local anesthetic agent. Usually, procedure itself it ends within 15 to 30 minutes. So, lidocaine is indicated, is recommended to give, but for prolonged analgesia, bupivacaine can be given. So, at 4 points, at somewhere it is written at 2 points. 4 o'clock and 8 o'clock, 5 ml of the local anesthetic agent can be given. You may go up to 15 ml. You have to use the specula to visualize the area. And results are, literature's shown the results are very excellent after performing these blocks. So, as a rule, as a principle, aspirate before injecting, and it is quite effective. So another block was the pudendal block, but I'm not going to discuss that in it. So the block selection algorithm in general, tab block is recommended for the abdominal procedures during the gynecological surgery. Quadratus lumborum block for the mainly for the pelvic deep pain, because जो QL3 block it covers the a little bit of the visceral pain as well. Paracervical block for the cervical and uterine, pudendal for the perineal surgeries. Similarly, analgesic algorithm, you can use preoperatively NSAIDs and gabapentin wherever it is indicated. In few guidelines for few surgeries, gabapentin is not recommended because they haven't find the sufficient evidence, supporting evidence. And furthermore, gabapentin is associated with a lot of sedation. So if just imagine if you're going for a daycare surgery, patient will remain drowsy at the time of discharge. So again, it's a drawback of gabapentin. Otherwise, for perioperative pain management as an additive, it has a very good profile. Intraoperative regional blocks, wherever possible, go for it. It is inexpensive, easy to use, and multimodal analgesia obviously is the basic principle. Um, Another important thing is that opioid we don't have around the year available in our country. So it's better to go for the local anesthetic agent wherever we can use. So final take-home message is regional blocks improves outcomes as the studies have shown. Use the multimodal analgesia and ultrasound guidance is essential. It's a one-time investment, and the outcomes are very excellent by using the ultrasound. You will get the precision in your blocks, success rate will improve, and complications will reduce. But again, there is a lot of literature in which those patients who received only the regional block, peripheral nerve blocks alone, they've shown higher incidence of breakthrough pain and 48 hours uh, consumption of opioid is more in those patients who have had regional block alone. So it is very important to go for the multimodal analgesia. So as when the effect of the block start wearing off, it will covered by the NSAIDs or whatever the medication that you're using. Okay, thank you. Questions, please. Queries and questions.
Assalamu alaikum.
Welcome, Salam.
Thank you, Dr. Azhar, for a very excellent and well-structured presentation. I am Dr. Asam. I am working as consultant anesthetist in King Salman Medical City, Medina, Saudi Arabia.
Welcome.
Thank you very much. My question is that what is the plan for a laboring mother pain management who is already fighting with her chronic cancer pain with strong opioids? And second question is the labor analgesia option in a mother with sickle cell crisis. Kindly share your own expertise and also your institutional policies regarding these patients. Thank you very much.
Okay, so the first patient that is having a malignancy and coming for the laboring pain, now in such a case, now it depends what was the cancer in that patient, which area that is affecting it. For instance, if a patient is having, for instance, having a cancer of large gut or pancreatic CA, in such a case, we can go for other interventions as well to settle down the pain. Um, we can continue the opioids wherever possible, and we can turn it off just at near the day of delivery, so as to minimize the risk in the newborn. So in such a case, again, a regional technique is excellent to cope up with the pain. We can use intrathecal morphine. I'm sure that is available in Saudi Arabia. So that can be used. It has an extensive duration of action. It covers the pain for at least 24 hours. So that can be used in it. And the other one is the sickle cell crisis. Again, sickling will increase if the patient has is having pain or having any other stressful factor. So again, in such a case, we can go for the conventional therapy. That is, we can go for the labor epidural to make the patient as much comfortable as we can.
Thank you very much. Just want to ask that is there any change in the dose regime for the patient who is already taking the strong opioids?
Dose of what? Intrathecal? You're
Yes,
talking about intrathecal
you
opioid?
mentioned you mentioned the intrathecal opioids. I'm
Yeah.
just wondering if she's already taking strong opioids, combination of morphine or pethidine, something like that.
Mhm.
So, what is the dose regime changes in intrathecal opioids if we consider this for this pain management?
Okay. The intrathecal opioid itself is it is so minimal that usually it does not causes overdosing or drowsiness in it. So, for instance, here we use the fentanyl, although its duration of action is not very brief as compared to the morphine. But the dose that we use is roughly around 15 to 25 microgram, which is very minimal. Similarly, in case of morphine, usually these cancer patients, especially, the pain is so intractable that most of the time, these even female patient or elderly patient, they are on a higher dose. So one thing that you can do or we can do is to turn off the last dose of the patient if they are taking oral opioid, oral morphine, and after that we can give the intrathecal morphine to the patient.
Thank you very much.
Yes, any other
Thank you,
question?
sir. I like to invite other questions as well. If you have any queries, kindly comment in the chat box. And any senior, if you any of you people want to comment or want to discuss something, you're welcome.
Yes, any experience, lifetime experience or something like that. Doctor, I can see Dr. Lina Z is here. Um, she's a very senior consultant in Ghurki Trust Hospital.
Assalamualaikum.
Ma'am, Assalamu
Azhar,
alaikum.
Walaikum Assalam. Azhar, it was a beautiful presentation. You covered almost everything in such good details. And I think in the public sector, is kadar load hai. I'm sorry,
Exactly.
a lot of load on the public sector here in Pakistan that
Yeah, true.
unfortunately the level of pain which we should be giving to the obstetric patients, it is not met. And I wish and I pray that all the institutions can cope up with all the services which you are giving. We are trying our level best, but inshallah, we are hopeful that we will be able to. And as you mentioned, ultrasound is the new way, and we should go ahead with it. Tap blocks, we are using it already. And well, let's see. Things have improved quite a bit, but need a lot of work to be done on it. Thank you very much. Well done.
Thank you, Dr. Lina.
Uh, Dr. Azhar, I am Dr. Shahid from PIMS. I have a question.
Welcome, Dr. Shahid.
Sir, have you any experience of erector spiny block in patients undergoing laparotomy for gynecological procedures?
Yeah, on and off, we have used the erector spinae block. You have specifically asked about the gynecological procedure. Yes, we have used it.
Okay, but what as compared to tab block, what you suggest? Which one is good regarding pain control or regarding post-op
Yeah, what I've
uh,
seen in the
duration?
although in the guidelines which I've gone through, they haven't mentioned the use of erector spinae block for the midline laparotomy, especially in the debulking surgery. The reason which they have given is that they don't have sufficient evidence for that. But as obviously we not all the time we go through the guidelines. Sometimes we give the intervention as an alternative. If you don't have one thing, you can go for the other. If they haven't mentioned the use of erector spinae block, that doesn't mean that this block will harm the patient. We can use it. And if you talk about the tap block, erector spinae block, what I have seen, it has a relatively a more longer duration of action, and it covers more area of the of the abdomen as compared to the tap block.
Okay,
Sorry,
sir.
sir. I'm again.
Thank you. Thank you.
Once again, what's about your opinion regarding a combination of rectus spinae block and rectus sheath block?
Erector spiny and rectus sheet. If you are doing the erector spiny block, it covers the anterior area as well. So doing the rectus sheet block would not give an additional benefit.
Okay, thank you very much.
Thank you.
Erectus spiny is considered to be almost a posterior tab block, isn't it,
Yeah.
Azhar?
Yeah, it is considered in a literature. It has been said that it is a epidural of the uh, peripheral nerve, but it is a substitute of the epidural because it
Very
covers the
true.
whole of the posterior anterior area.
Yes.
Yeah. Yes. Any other question?
Anyone else have any other question?
Okay. If
Sir,
anyone has
can
any,
you, Assalamu alaikum, sir. I would like to ask a question.
I guess Dr.
I
Azhar, you have explained it. So,
yes, yes, Dr. Anand, please go on.
Sir, can you please provide me some experience about uh, planning regional, especially for obstetric patients which come with low EF, and especially when they're coming in heart failure?
Mhm,
We had an experience in our setup. Unfortunately, we do not have fentanyl with us.
mhm.
We do have ropivacaine, we do have bupivacaine, but unfortunately, we do not have any opioid to add in. So we do get these patients who have a ES somewhere around 20 and 25, and they always present like a dilemma. So, sir, if you could update my knowledge about them or how to approach such patients and what is better for planning regional when it comes to these patients, because they're always risky and the risk is always there.
Okay, so for the peripheral nerve blocks, for example, could you specify the surgery? Was that patient for the cesarean section or for gynecological surgery?
Sir, for both, I always have a
Okay.
query if I'm planning for a gynecological surgery. For example, if you have a hysteroguided biopsy and the
Mhm,
patient presents somewhere with a EF of 25, but we
mhm.
have to do the hysteroguided biopsy, and they say no, we have to plan it, and we need a biopsy so we can plan further. And even if this patient is coming for a emergency section or whatever, it could be elective section, and she has a 25% or 20% EF and has shortness of breath, has cramps and edema going on in the lungs, and we have to give anesthesia to both these patients. What should be the approach and what is better? And if we plan regional and we do not have opioid, what are the recommendations? How should we proceed with them?
Okay, so for the minor procedures such as patient is coming for DNC, for stereoscopy, paracervical block can be given but again, practically it is not in very much practice. So pain is covered from there. Along with that, you can give some sedation as well. But we have experience in the major surgeries such as midline laparotomies. In such a case, thoracic epidural analgesia, it works wonderful. It works wonderfully. So just go to the,
So,
for instance, if you are giving a midline incision from the Xiphi sternum to the symphysis pubis, insert the epidural, just leave the epidural catheter roughly around at the level of T6, T7 or T8. At this level, you insert the epidural catheter and give the local anesthetic agent. If you don't have any fentanyl, that doesn't make a major difference. Give it in a concentration of 0.1%. That will cover the pain component, and along with that, you have to do the general anesthesia as well.
sir, for what about going for a section? Point one won't be adequate.
Yeah. For cesarean section, you can if you cannot do the you mean to say if general anesthesia is contraindicated?
Can I come in?
Yeah, yeah. What I want to know is how to approach these patients where we cannot safely give general anesthesia.
Okay.
So
Dr.
I
Anand,
want.
I had an experience similar with the case scenario which you are giving. We did a laparotomy on a patient who was almost the same situation which you are giving. We did an lumbar epidural, but we gave the dosage in stages. We took about 20 minutes or so for the anesthesia to work up, and we started the laparotomy. And the position of the patient was almost a little semi sitting, you can say. And we were able to build her up for about 20 minutes or so. And then we proceeded with the surgery. Oxygen was given to that patient, and we had this experience. We didn't have morphine, but we went with the lumbar epidural and gave the doses
And
in
madam,
interval.
I'm sorry, were you using Xylocan with that, or you use Xylocan plain?
We did a combination of xylocaine with bupivacaine. We didn't have anything else. We were in a government setup, and we didn't have anything, and we went in stages, and we were able to
Madam,
get
can
it.
you share your experience? Like, how much did you give? Was it a total 10 ml of Xylocan with add, and then you
No,
added up the Bupropion, or was it 5 plus 5?
no, we gave her point 0.25 bupivacaine. We definitely used, but we added xylocaine, which was also 1%. And we built her up, and we took about 10, 15 to 20 minutes to achieve the level, the dermatome level which we wanted to.
Thank you so much, madam. Thank you.
I will add one thing that if patient is stable with low ejection fraction, it doesn't mean that she can't be given general anesthesia. We can use opioid based technique to give general anesthesia if suppose we want to avoid regional in those patients.
Yeah.
But if the patient's chest is very wet and you don't have opioid, which is the normal circumstances which we are facing, then yes, first choice is GA. But if the patient's condition allow, but if
Yes,
not,
yes, yes.
then you have to improvise.
Yes, if doesn't allow, then your technique is also good. You just mentioned keeping the patient prop up and increasing the dose of epidural to achieve the level.
Yeah, even I've we have experienced very frequently that patient who have cardiac disease, usually valvular valves are involved in it during the time of gestation. Um, for labor purpose, these patients have a labor epidural in place, and if they are going for the epidural for the cesarean section, so we load it with the small increment of the local anesthetic agent, and most of the time, their cesarean is not a emergency procedure. It's a sort of semi-emergency, so you have time to build up the level of analgesia. So by
Exactly.
giving the incremental doses with a little bit diluted solution, 0.25%, although motor power will maybe it may remain intact, but sensation you will cover it. So this is the way that we do in our hospital patients who are relatively high risk.
Thank you so much, sir. Thank you.
Uh, Thank you very much. Thank you, Dr. Azhar. Your lecture was really informative and insightful. And I thank you, Ma'am Leena and Dr. Shahid also for sharing your experience and your comments. I have shared the feedback form in the chat box, so you can fill that, and your certificates will be delivered, emailed to you. Thank you very much. And
Thank
with
you.
this, we conclude this with this session. We conclude this lecture series. This was the last lecture of the gynae and ops session. And next on, we will be starting our new module, that is the cardiac uh, chapter. And the first lecture will be on 5th of January. So I sincerely thank all of the speakers and participants for their contribution, and I hope that this knowledge help you in your practice, and I thank you all for being the part of this series.
Thank you. Thank you, all of you.
Thank you, Dr. Azhar. Thank you very much.
Thank you.